Hello and good evening to you all. I hope you can hear me as always. And I am your host, Caroline. And of course, I would like to welcome you to our online patient meeting today. And it's good to see you, Dr. Alex. Hi, how are you? Hope you can hear me.
Hello, fine. Thank you.
Perfect.
Good evening.
Good evening. Please just let us know if you can hear us so we are sure that all is working properly. We would really appreciate that. And of course, let me just start with a few words on our Stronger Together initiative. As you know, we are meeting here every single day from Monday to Friday to support you throughout those uncertain times for sure. We definitely all are waiting for this to be over so that we can get on with our normal lives. We are definitely focusing on starting our your treatments as well, and I really do hope it's going to be possible very, very soon. But this point, since it's not possible, we are just here to support you however we can, and we know that asking questions the doctors and also meeting those top experts is definitely something that you need. And again, let me remind you that it wouldn't be all possible without our partners, ambassadors that you can see right here on the screen. So huge thanks to them as well. And of course, today with us, as I've already mentioned, is Dr. Àlex García-Faura from Institut Marquès, located in Barcelona, Spain. And today he will be happy to answer your questions. So remember that you can type those in the chat section, and Dr. Àlex will answer them for you one by one. And today our topic is the more additional techniques, the better success rates, the medical evidence. So he will explain all the details on those techniques. And as I've mentioned, first we will start with some of the common questions that we receive from the patients, and then it will be time for your questions. Well, I guess that will be it from me. Dr. Àlex, are you ready to start our meeting today?
Thank you very much for the invitation. Hope you're all well. And well, I guess that one of the good things about the confinement is that everyone will be able to connect today and well ask any doubt or any question on the topic about additional techniques on IVF treatments. Just a few words about our clinic and about the main additional techniques that we can use on IVF. Well, I'm Dr. Garcia-Faura. I'm the scientific director here at INSTITUT MARQUES. So I guess I'm the right one to ask about any question on scientific or medical evidence. Our clinic, INSTITUT MARQUES, is one of the top integrated centers with a well-established, international recognized reputation in the field of obstetrics, gynecology, and assisted reproduction. And every year, hundreds of patients visit our clinic from all over the world, hoping to achieve pregnancy, mainly through IVF with egg or semen donation. Our headquarters are in Barcelona, just as Caroline said, and we have additional offices in the UK, in London, in Ireland, in Dublin and Clane, and in Italy, in Rome and Milan. Well, with more than 95 years of history, the fourth generation of gynecologists, now Dr. Borja Marquez just came to the clinic, continues to deliver stunning results, and the clinic has become an international reference for assisted reproduction. We are happy to say that we are at this moment leaders in excellence-based medical care, and we're treating patients from more than 50 countries, and we have a broad portfolio of services and obtaining the best success rates, reaching up to 91% of success in our egg donation programs. About the question of the topic that we're talking today, which are the additional techniques that we should be doing in our treatments, or which are the best techniques to get the best success rates. I guess that Caroline will ask some questions referring to all these techniques. But of course, one of them, of the most important, is PGT, prenatal genetic testing, which will help us to see which embryo is normal and has the possibility of giving us not only a pregnancy, but an evolutive pregnancy and a newborn. That's what we want. Of course, all the techniques referred to the male factor, which include ICSI, IMSI, and fertile, and that will help us reducing repeated failures due to male factor. All the techniques and all the tests that can be done in recurrent miscarriage, and also all the other techniques related to the lab, to the incubators, such as time-lapse technology, which is Embryoscope, and the embryo mobile technology that allows the patient to watch the embryos on real time at home. Of course, there are some other techniques that we can discuss, we can talk about, but I think that probably we could start with the main questions so that I can give you some more details about all these techniques. Thank you, Caroline.
Perfect. Thank you so much. Yes, we can definitely start with those most common questions from the patients that we receive from the patients. But of course, remember to type in all of your questions after the most common ones. We will definitely go ahead with your questions. So let's go to the very first one. So, are there any conditions or factors which can influence on results, and what patients can do?
Well, of course, there are some conditions that we can treat, some other conditions like maternal age that we cannot treat at the moment. And of course, I think that one of the most important factors is maternal age, especially for IVF with own eggs. I think that we all know that when we go over 38 or 40-year-old, we have high risks of repeated failures and also recurrent miscarriages. Of course, we cannot change that. And that's why when we have patients over 42, 43, 44, most of them will finally decide to go on egg donation or embryo donation programs. So there's no possibility, there's no chance to treat the quality of these eggs. But of course, we have the option to use the donor's egg or the embryos that have been abandoned or donated by some other couples. Of course, there are some other conditions like ovarian reserve or egg reserve that sometimes we can just diagnose, like in the cases of endometriosis, or those patients that have had surgeries on the ovaries. There are some specific treatments that we can do, especially on ovarian stimulation, to try to increase the quantity and the quality of eggs that we can get on the retrieval. But again, we cannot change the patient's ovarian reserve. And in those patients, even in young patients that have almost none of ovarian reserve, again, the only option would go to a donation. Of course, there are some other conditions like the uterine factor, which means that the uterus has an abnormal shape or the endometrium has some problems in it that we can diagnose and we can treat before starting any treatment, usually by minor and simple techniques like hysteroscopy, where we're able to see the cavity, to see if there's something wrong inside that is giving a repeated failure or recurrent miscarriage, and just treat it to increase the chances of implantation of an evolutive pregnancy. I don't know if there is any other, well, we will see later if there is any specific question on this topic, Caroline.
Okay, perfect. Thank you so much again for answering that question. And yes, there will be more detailed question coming. So thanks for. Let's now focus on those though. What you can really do if male factor is involved?
Well, of course. first of all, well, it's great to get to know if there is a male factor involved. Spermogram sometimes is not enough to give us a precise diagnosis. So we know that probably around 50% of failures in egg donation problem are due to an unstudied male factor or a male factor that hasn't been diagnosed yet. So in our clinic, the study of male factor before starting any IVF treatment and any egg donation treatment is very important. Of course, starting with an interview with the chief of andrology, physical examination, and getting some specific tests depending on the previous treatments that the patient or the couple already had. Of course, there are some tests that can be done, like DNA fragmentation or fish in semen samples, that can give us sometimes the idea of the risk of repeated miscarriage if DNA fragmentation is high, or the risk of abnormal embryos when fish is abnormal. Of course, there is always the chance of going directly to, this is done on semen samples, but of course, sometimes we need to go to test this biopsy to discover if there is abnormalities in the chromosomes of spermatozoa. Of course, we can treat when we have this male factor and we have already diagnosis. There are some techniques that we can use, such as specific sperm selection techniques, as ICSI, IMSI, or fertile, that can help us selecting the healthiest spermatozoa to try to increase the fecundation rate and to increase embryo quality up to blastocyst. These techniques, of course, depends on the diagnosis. And if there is an abnormality on chromosomes, of course, we do always have the chance of PGT-A, which is a prenatal genetic testing, to make sure that even if we are creating some embryos with an abnormal numbers of chromosomes, we're able to study these embryos and be able not to transfer them, and only transfer those embryos that are normal, have a normal number of chromosomes.
Perfect. Thank you so much again for answering that question. And I believe there will be more questions related to this, but let's go to the next one first. What gynecological condition can lead to failure?
Well, I'm sorry, I think I already partially answered to this question.
Yes,
in the
that's true.
first one, talking about uterine abnormalities and endometriosis, were I think that the most important gynecological conditions. Mm-hmm. Of course, there are some other gynecological conditions that can lead to failure, especially with those patients that had uterine or ovarian surgery, and especially in those patients that had oncological treatments, that had survived to ovarian cancer, to uterine cancer, or even to breast cancer. And of course, that will give us a poor or almost non-ovarian reserve. Of course, these patients should be evaluated by a multidisciplinary committee. We do have an oncofertility committee to evaluate these cancer survivors and to guarantee that we're not increasing the risk of cancer, and we're giving them the highest success rates to achieve the dream of having a baby.
All right, perfect. Thank you so much, Jan, for answering that question and adding some more details on that as well. And why do not all embryos implant? Is PGT-A, PGS a solution?
Well, for repeated implantational failure, of course, we know that up to 70% of cases is due to embryo abnormality, to an abnormal number of chromosomes. Of course, this will be increased in those patients over 35, and of course, always over 38 and 40. We know that at 38, probably 70% of the embryos will be abnormal. At 40, probably 80 or 85% of the embryos will be abnormal. And between 43 and 45, probably almost 99 or 100%, almost all the embryos will be abnormal. So, of course, these abnormal embryos would either not implant and give us repeated failure or give us early first trimester miscarriage. So PGT-S, which refers to prenatal genetic testing for aneuploidies. PGS is the old way to, it's prenatal genetic screening. That's the term that we used many years ago. Not PGT-A is the right way to spell it. Will help us avoiding to transfer these abnormal embryos and reducing the chances for negative tests and reducing the chances for repeated miscarriage. It doesn't matter if it comes from the ovarian factor or some patients, in some cases that comes from a male factor, genetic male factor with an abnormal karyotype or abnormal number of chromosomes in the spermatozoa. So, of course, PGT-A will reduce the chances of repeated miscarriages and repeated failure just because we are avoiding to transfer those embryos that are not able to implant or that will implant and will always give us an early miscarriage. So yes, I think that PGT-A, of course, in some specific cases, or sometimes as an elective technique in those patients that want to make sure that they are transferring a normal embryo, even if there is not a risk factor, will reduce the time to give us an evaluative pregnancy and a healthy baby at home.
Okay, perfect. Thank you so much. And in such case, so would you recommend PGT-A for egg donation cycles?
Well, of course, in egg donation cycles, we're reducing the chances for chromosomal abnormalities coming from the egg, just because we're using eggs coming from donors between 18 and 33, 35-year-old donors. So we're reducing quite a lot the risk for aneuploidies. But as I said before, in those patients where there is, or we suspect, a male factor and a chromosomic or genetic male factor, PGT-A will again reduce the chances of transferring an abnormal embryo. And again, in those patients that just want to make sure that we're transferring a normal embryo, even if we do not have a male factor and we're using young donors' eggs, PGT will avoid any transfer that we shouldn't be doing, any transfer of an abnormal embryo. And we need to realize that IVF, the technique, the treatment, we know that it increases the risk of aneuploidy. So PGT-A is always an option with a medical indication or as an elective technique.
Perfect. Thank you so much again for answering that question. And now, if you could tell us about the role of endometrium in implantation failures.
Well, I think that for all the additional techniques that have appeared for the last 10 years, almost all of them have to do with the laboratory. So almost all of them have to do with the egg, with the spermatozoid, with the embryo fecundation and embryo development. And I think that we've been able to increase the chances, the rates, pregnancy rates, probably 15 or 20% during the last 10 years. But it's been only due to these additional techniques in the lab. I think that we still have a lot of research to do related to implantation and endometrium. I think that's the part that we should be focusing for the next 10 years. There are many trials related to repeated failures because of many factors related to endometrium, but there's still low scientific evidence to most of them. For following the guidelines of the European Society of Human Reproduction, the ESHRE, the only the only local cause for implantational failures are uterine abnormalities, which means having two uterus, a double uterus, uterus septum, etc. That's the only strong evidence. If we diagnose it and we treat it, we are able to reduce these repeated failures. Of course, there are some techniques, diagnostic techniques related to the endometrium, such as endometrium cultures, endometrial biopsy, and many studies that we can do on the endometrium related to the microbiota, related to the implantational window, related to immunity. But we still need further clinical trials and randomized clinical trials to tell the patients that these tests will give us the cause for implantational failure, and then the treatment will increase the pregnancy rates. I think it's too early to tell the patients that we have strong scientific evidence on all these tests that can be done on the endometrium. There's another factor, which is adenomyosis, which is endometriosis just under the endometrium, just in the muscular part of the uterus. And there are also some trials that show that adenomyosis will reduce the rates, the success rates, and that probably some treatments to reduce adenomyosis could help us increasing the results in this group of patients. But again, I think that the endometrium is, well, of course, we have the embryo, we have the endometrium, so half and half. I think that we need to focus on the endometrium for the next 10, 15 years because we still don't have enough evidence to tell the patients that we know why and we know how to treat it. Okay.
Mm-hmm. Okay. Perfect. Thank you so much for that information. Definitely interesting to know. And now let me show you a different question. So, are there any possibilities to affect oocytes quality?
What do you mean to affect?
I guess the quality. So it's better
to improve the quality.
Yes. Yes.
Okay. Well, of course, referring to quality, first of all, we need to talk about mature and immature eggs. When we stimulating the ovary, we try to get a high number of high quality eggs. First thing we need to talk about is about mature and immature eggs. So, of course, there are different protocols and different techniques to change ovarian stimulation in those patients that already had a high rate of immature eggs retrieved. And also there are some techniques to try to mature these immature eggs inside the lab, in vitro. Of course, these are still, some of them are still experimental techniques. We're able to get some mature eggs from immature eggs. But of course, at this moment, trying to improve maturity during ovarian stimulation is the gold standard. And in those patients that had poor results and a low number of mature eggs, what we are supposed to do is to change the protocol to try to increase the maturity and improve the maturity of these eggs. There are some other aspects related to quality that have to do with maternal age. Unfortunately, we cannot treat again the age of the eggs. We know that men will produce millions and millions of spermatozoa every single day. But in the case of oocytes, the patient will be born with a precise number of eggs that will reduce the quantity and especially reduce the quality every single year. And especially after 35 or 38-year-old, we know that this quality will keep on reducing and there is going to be damage on the chromosomes that unfortunately we are not able to treat. So in this aspect, we cannot change the quality related to age.
Perfect. Thank you so much again for answering that question and explaining that to us. Now we are shortly going to start with your questions. So just let me remind you that you can type them all in the chat section, and Dr. Alex will answer them for you. So if you are looking for any advice, this is your time. This is your chance to find out. Okay. Now let me go to the question about embryoscope time lapse. Does it help to select an embryo? Can it help in terms of embryo's development and quality?
Well, of course, time-lapse technology has become very important now that the gold standard is going to day 5 transfers, going to the blastocyst stage. Of course, many years ago, maybe 10 or 15 years ago, when we used to transfer embryos on day 2 or day 3, there was no sense on using time-lapse technology, seeing that the embryos just were in the incubator for a couple of days or 3 days. But we know that half of the embryos probably will get blocked when we try to go up to the blastocyst stage. And what we call the blastocyst rate, which means how many high-quality blastocysts we get on the average of total embryos created. Of course, trying to keep the best conditions for embryo development is important. And Embryoscope or any other time-lapse technology will help us getting the same temperature, the same humidity, the same conditions inside the incubator, just because we don't need to open it every single day for every patient. It gives us the opportunity to get a picture of each embryo every 5-10 minutes, and we've been able to see many aspects of the morphokinetics of the embryo development up to day 5 that will help us choosing this embryo that has the higher possibility of giving us a pregnancy. We've seen too that some of these abnormal divisions or abnormal things that might happen during development can be fixed by the embryo. And sometimes there are some abnormalities during development on day 2, day 3, that if the embryo is able to fix and get up to high quality blastocysts, we know that we can use it and that will give us the same pregnancy rates that another embryo that had the same problem and wasn't able to fix it. And only with this time-lapse technology, we're able to get these little details during embryo development that will give us a prognosis. Another thing, of course, is being able to watch the embryos on real time at home. Here at the Institut Marquès, we give the patients the opportunity through the embryo mobile technology to come to the lab, to enter the lab virtually and be able to watch the embryos on real time for the 5-6 days of culture. There was a very nice clinical trial that we presented last year at the ASHRE Congress and the European Society Congress that showed that those patients that connected many times a day to watch the developing embryos were able to get up to 11% higher pregnancy rates, probably due to psychoneuroendocrine immunology effect coming from emotions and going down to immunology on the endometrium, and being able to watch this embryo and getting attached to this embryo and the treatment just gave them a higher possibility to get a positive test.
Okay, perfect. Definitely sounds interesting. So you wouldn't think that such a thing can actually improve um, this. So it's indeed very interesting. And as I've mentioned, now it will be time for your questions, and we have a few questions already. So thank you, Dr. Alex, for answering those. Now let's move into the questions from our patients. There are a few Let me start with the very first one here. So what is the number of egg donors per year? Do you have any idea, any numbers that you can provide us?
What is the number?
Of egg donors per year. I believe how many donors, if I'm correct, if you could tell us just in case if I'm correct. Someone is typing yes. So how many donors a year you are recruiting, I believe, yes?
Oh, in our clinic. Well,
Yes.
first of all, I guess you know that in 2018, I think is the latest data that we got
Yes.
from the European Society of Human Reproduction. There were 50,000 of egg donation cycles in Europe. From those, 25,000 were done in Spain. And of course, there are many reasons for that. First of all, I think that it has to do, of course, with the recruitment programs that we have for donors. Of course, there's a difference with some countries like France, where donors cannot get any compensation for the treatment, and that in Spain we're allowed to give this compensation, even if it's not high compensation, just good enough for the days that they cannot go to work, the placement, etc. And of course, getting half of the egg donation treatments in Europe, I think that has given Spain the possibility to develop these high quality recruitment programs for donors, trying to get good matching with the patients and being able to, of course, do the best selection for each patient. Of course, at this moment that we are confined, the number of donors that we have for treatment are zero, and the number of patients too, unfortunately. But of course, in our unit, we have, if not hundreds of active donors that are waiting to start treatment. But of course, it depends on the blood type, on the physical characteristics, etc., to get to know that when will they be ready to start for a specific patient. So of course, the number of donors that will start a treatment depends on the number of patients that will come and start treatment in our clinic. We're getting patients from more than 50 countries coming for egg donation programs. And of course, we do have donors from all ethnicities and all physical characteristics to our patients.
All right, perfect. Thank you so much for your question and answering that one as well. And you have already mentioned it, but if you could add anything to it. So you said about watching embryos live from home. Could you please give us some more details on how it works? Anything additional you could tell us?
Well, I can tell you the best way to do it is to Google it and look it for in Google. We are the only clinic in the world at this moment that gives the opportunity to connect from your phone, your tablet, any mobile device to our laboratory during the embryo culture days. Patients will receive an encrypted link to their email address, and themselves or sometimes the referring clinicians can click on this link and connect as many times as they want. Our clinical trial on watching these embryos was dividing patients on how many times they connected every day. We had patients that connected once a day, some of the patients that connected up to 10 times a day. The group of patients that were able to get the highest pregnancy rate were those patients that connected up to 30 times during the whole culture, which means around 5-6 times a day. And it's quite easy, you just need to click on the link and you can see if you have 5 embryos, you will see 5 images, and you can update it every 5 minutes. So you're able to keep on tracking the development of your embryos and see how develop even if you are 10,000 miles away. It's quite a nice technology.
Definitely fantastic, definitely useful. I am sure many patients are finding this quite interesting. And as you are one of the only clinic in the world that do it, definitely something to look out for. Thank you.
Well, it's quite important for us. Of course, it has to do with emotions. It has to do for the patient to feel that she's following a treatment even if she's not here with us, just getting attached to this treatment. But of course, I think it's important from a point of view of transparency, just getting to know that we tell the patient is what she can see. And even if patients are not embryologists, they can keep the image and they can check with an embryologist that what we say is what they see on the screens.
Yeah,
I think it's quite important.
Pretty clear then, exactly. Perfect. Thank you so much. There's another question coming up here. So egg donation programs, only 2 eggs are guaranteed. Why not 3 or 4? Is ours in other clinics? Any comments on that?
Okay, I think that they mean blastocysts.
I believe embryos as well, but if you could just make
well,
sure.
I think guaranteeing blastocysts is fantastic, but of course, in egg donation programs, what we can guarantee is the quantity and the quality of the eggs. But of course, we cannot guarantee the quality of sperm. So, of course, being able to guarantee a specific number of blastocysts, I think is not fair, seeing that if we have a severe male factor, we need to tell the patients that probably we won't be able to get a high number of high quality blastocysts. And we need to look how to increase these chances of getting high quality blastocysts. Again, and as I said with the previous question, of course, the number of blastocysts is important, but being able to make sure that the quality of these blastocysts is the one that we tell is what the embryo mobile technology gives to the patient. So being true, if we have poor quality blastocysts and this blastocyst will never be able to give a pregnancy, this doesn't count. We should never transfer these embryos. We should never freeze these embryos. And of course, giving the patient the opportunity to keep the recorded video of all the embryo development gives them also the opportunity for a second opinion and make sure that if we transferred high quality blastocysts, they can check it, they can verify it. The average of blastocysts that we can get in our program, I think the last data that we had is 2.8. Of course, this means that some patients will get 6 blastocysts, some other patients will get 1. Of course, it depends, as I said, not only on egg quality or quantity, it depends on male factor.
Perfect. Thank you so much for explaining in detail all the factors here in such case. Definitely important. Okay, there's another one coming. So do you use or know any medical evidence of using the embryo glue?
Okay, as I said, when we talk on endometrial factor, I think there is still little evidence about using any compound inside the uterus during the transfer or before the transfer. There are many ongoing clinical trials on growth factors instillated inside the uterine cavity or some other products that we can use during or before the transfer to get to increase pregnancy rates. And again, I think there is not at this moment enough medical evidence. And we used to see multi-treated patients that had many treatments, patients that had many additional techniques related to this endometrial factor, and of course, using embryo glue or using any other technique without having tested if the embryos are normal by PGT-A is not worth it. So before using any low evidence technique, I would strongly recommend to use all the strong evidence technique that we have. And we see many patients that have had many treatments without doing almost none of this strong evidence technique and undergoing many low evidence technique just before doing the right things. So, of course, after using all the available techniques with strong evidence, if we still have repeated failures, there are some other techniques that we can add, but never the other side.
Fantastic. Thank you again so much for your question and you helping out with for us. So let me go to the next question. So I am turning 40 in a few weeks, hoping to start IVF in May, but obviously due to COVID-19, this will not happen. Is there anything you can advise me to do while waiting?
Well, of course, at 40, I think that the most important thing, as we said, is egg quantity and egg quality. Of course, we are not able to start any treatment, but during the confinement, we might be able to get some tests done. It depends on the country and the region. Of course, in some countries, you can only go to your doctor for emergency. You cannot go for standard tests just because I think that all doctors and in many countries, clinicians are just working to fight this epidemic. But of course, if this patient has the opportunity to get the test done to check her ovarian reserve, such as the anti-Mullerian hormone or ultrasound with antral follicular count to count the follicles in each ovary, I think that she could already know the chances of getting at least quite a high number of eggs or not, so the quantity of these eggs. And of course, she could start reading about PGT-A because, of course, after 38, getting all the information that about the treatment that you're supposed to do is important, and probably getting the right information from the right clinicians is important, and be able to ask any questions she might have. Probably if she wants to have IVF with her own eggs, it would be nice to get an appointment by Skype. We can do that and be able to ask any question on the PGT-A additional technique that I think it would be worth for her.
Yep. Emma just added that she has been to Klein and her results are
Great.
fine. Just wanted to add it here.
Oh, fantastic. Great. Well, of course, as I said, we keep our activity by Skype or phone. And I think what we can do is assess the patients. And I think that we can lose these months or we can take advantage of these months. And of course, being able to get all the information about the treatment and having the opportunity to get a virtual appointment with a specialist is the best thing she can do during these months.
Mm-hmm. Perfect. Thank you so much.
Thank you.
And can you have a look at this one? Have you noticed a difference between an antagonist or agonist, a protocol for a plus 40 years old woman for IVF with own eggs?
Okay, the agonist protocol, especially for, well, usually over 40, what we have is low responders. So they are over 40 and usually they have a low response, which means less than 9 or less than 5 eggs for each ovarian stimulation. There are different protocols for low responders, both with antagonist and both for agonist. Probably the lung, which is called the lung agonist protocol, is the one that will give us the highest quantity and the highest quality of eggs. But of course, in some patients that do not give us an answer, a good response with the agonist protocol, we can also try an antagonist protocol, ultra short protocol with high doses. So both are possible, but probably the latest evidence will give little advantage to lung protocol with agonists.
Perfect. Thank you so much for that advice as well. And we have a longer question, so let's have a look at this.
Okay.
Then I was advised that NGC is even better, so I decided to do that. However, now also you might have problems flying to and from South of Europe. I'm thinking it might be better doing only PGT-A, as I would only need to fly once and stay for a week. How much better is NGS than regular PGT-A? How common are these you screen for NGS? I am 41.
Okay. NGS, well, NGS, PGT-A, we should explain which are the differences. PGT prenatal genetic testing is related to all the tests that we can do on the chromosomes and genes of an embryo, okay? There are different PGTs. PGT-A looks for the number of chromosomes. PGT, let me remember that. The PGT, there's another PGT for specific genetic monogenic diseases, which are families that have recessive disease and we want to study it. And there's another PGT for patients that have chromosomes where part of the chromosome has switched to another one. But of course, this has to do with the reason and what we want to look on this genetic material of the embryo. NGS and is related to the technique where we're doing that. So you can have PGT-A using NGS. So there are different types of testing. There was a few years ago the fish studies for PGT, and now we have the gene sequencing. We can sequence almost all the genome from an embryo. So I think there's a little doubt, there's a little misunderstanding for the patient, because PGT-A is the reason why we're doing the technique, and NGS is the technique that we're doing to get to the diagnosis. So I think that that's what we do. We do PGT-A by NGS. Mm-hmm. We don't do one or the other one.
Okay.
I don't know if you want to re-ask the question.
Well, actually, there's a follow-up actually right here. Okay. So it's not the specific disease I'm after, just the one that checks for Down syndrome. And
then what we do is PGT-A by NGS.
Okay, perfect. Okay. I believe that was explained very well. Thank you so much for letting us know how exactly it works. And now there's another question, a different one. Which time-lapse system do you use at your clinic? Is it Embryoscope or Gary? Are they much different? Is the time-lapse recommended, and do most of your patients use it? Mm-hmm.
We're using at this moment, and we've been using for many years, the Embryoscope. Of course, it has to do with the results that we have with the Embryoscope technology, but it also has to do with the technique that we use to share this image with the patients. And we were able to do it with the Embryoscope, but we've never tried to share the data from a Gary device. Of course, we have Embryoscope in all our labs around Europe, and we do not have at this moment any Gary. Probably, well, because we used to use Embryoscope, which was the first one, and because the embryo mobile technology, at this moment, we wouldn't be able to use it at Gary. And for us, it's very important to be able to share this information with all our patients. There were many trials comparing time-lapse technology devices. I think there is not we cannot say that there is a winner from a scientific point of view. I think both of them will keep the best conditions for embryo development. Both of them are closed incubators, so we do not need to get the embryos out every single day. So at this point, I think that probably they're both giving the same. And what changes, especially software, related to how we do evaluate the images that we get from Gary and from Embryoscope. So making work easier for the embryologists, and different tools that will probably be increasing for the next years, that probably won't change the results, but will give detailed information about embryo development for these 5-6 days. And yes, we recommend Embryoscope to all our patients. I think that we use conventional standard incubators to heat the plates for the next day, but I think there are almost never, we do almost never have developing embryos in standard incubators. I think that almost all our embryos will grow in time-lapse incubators.
Mm-hmm. Okay, thank you for explaining this as well for us. There is actually a follow-up question about the previous one regarding NGS and PGT-A. So doesn't that take a long time to get the results? Isn't another type of PGT-A quicker?
The technique, the gene sequencing can be used on any type of sample that we can get on the embryo. Probably the difference, probably what the patient is talking about, is getting biopsy on day 3 or day 5. When we do the biopsy on day 3, the embryo has 8 cells. Probably we will take one single cell, and by NGS, we will test this cell for the 46 chromosomes. We're able to do that in 48 hours. So the patient will be able to have transfer 2 days later. We'll be able to get the result on day 5, so we can get a transfer on day 5, just 2 days after the biopsy. That's the quick way to do it. Of course, when we do the biopsy on day 5, we will take around 8, 10, 12 cells from the trophectoderm, which is the part that will give us the placenta. And we won't be able to get the result up to probably 2 weeks later. So we should always follow a freeze-all technique, and we won't be able to do any transfer during this cycle. We need to wait for the next cycle to prepare the endometrium and get the transfer, because we won't be able to get the result probably sooner than 13 or 14 days. I guess that's different. The day of the biopsy, not the technology. NGS, that's what we do.
Okay, I believe that patient just wants to make sure that she understands correctly. As I was told that if I do regular PGT-A, I would need to go abroad for about a week. For NGS, I would need to get back after a month. So is that correct?
I think that this again shows if we're doing the biopsy on day 3, on day 5, but it doesn't have to do with the technique. It has to do with the day where the cell was retrieved and not the technique. It's exactly, we're using PGT-A, NGS, both for day 3 and day 5. And of course, if we do it on day 3, the patient can come for the pickup and then have the transfer 5 days later. If the patient does the biopsy on day 5, she will have to come back for an cryotransfer.
Okay, I believe that now is explained. But of course, if you have any additional questions, just go ahead. We will get back to you.
Great.
Good. Perfect. And let me just go to the next question. Do you use Embryogen and Blastgen culture media, and do you recommend it, or does it not make much of a difference?
Okay. Well, probably I'm not the right one to answer this question. Probably it would be great to get the embryologist to answer about the type of culture media that we use. I know that we're testing different media culture, and especially now that we're going up to day 5 on time-lapse incubator, in most of cases we need to use single-step media cultures, which means the same culture for the 5 days. I really don't know the specific brand, Embryogen or Blastgen, but of course there are some differences, especially now that we moved, I guess that 95% of our transfers are on day 5. So it's quite important. Media culture is one of the most important parts. But of course, we need to test them, and we test different media cultures just before included in our incubators. Related to media culture, of course, I think it's quite important to say that the embryo in the incubator stays static; it won't move. So many years ago, we started a trial to see the effects of music during this culture. Just because we know that in nature, the embryo will move through the fallopian tube for 4 days, and in the incubator, the embryo stays still. So during these days of embryo culture, any toxin will accumulate around the embryo, and the oxygen and other nutrients will get every day a little bit away from the embryo just because he cannot move. The embryo will stay static. So I just wanted to tell you that we play music inside all our incubators to try to move this media culture and avoid this toxicity during embryo development that happens inside the incubator. Well, it doesn't matter which type of culture media you're using, and we're just moving this media culture with musical vibrations. And we already presented that we can increase fertilization rate up to 5% using music, and we can increase embryo development and improve embryo development applying these musical vibrations during embryo culture. I'm sorry that I cannot answer to this specific embryo gene on blastogen question. Probably an embryologist would be the right one to answer this specific question.
Perfect. Thank you so much. Anyway, of course, and remember that you can also get in touch with the team. Okay, I will send you a link where you will be able to simply send your message and to Institut Marquès team, and they will be able to simply just check it with the embryologist just in case as well. So this is the link you can use. And actually, it's good that you have mentioned the music that you're playing to the embryos. This is definitely fascinating, and actually we have a question on that. So does the technique really help in better development of the embryos? You already said that it does. And is there like which kind of music particular have you been able to check it as well, or?
This has to do with a large project of research project that we did. We started in 2012. That is the effects of music at early stages of life. We started with music inside the incubators, and then we continued with music during early pregnancy and during pregnancy, developing to a specific device which is called the baby pod to play music during pregnancy, but not through the belly, through the mother's vagina. And there's a whole project on the effects of music, specifically during embryo development inside the incubators. As I already told you, that we saw an increase on fertilization and blastocyst rate. But of course, the embryos don't have ears. So I think it doesn't matter if it's heavy metal, rock pop, or classical music, because all of them will give us this media culture movement just because of the mechanical vibrations that any type and any kind of music will give inside the incubator. So we found that we're able to increase these rates, but we didn't find any significant difference depending on the type of music. And of course, all our embryos inside the incubators do have 24-hour concert inside the incubator. Last year, well, we have had many concerts in our laboratory. I think it was last year that we had Sharon Core and from the course and Alex Ubago that came to our laboratory to play a concert to all our embryos around Europe, to all our laboratories. And the patients had the opportunity to watch the concert and at the same time to watch the developing embryos, which from an emotional point of view was fantastic, was great.
Yes, definitely sounds fascinating. And they had like a live concert as well, right? So
yeah, I think it's great. And of course, the patients, when they get the images of their developing embryos, they know the type of, well, the music that we use to incubate, even if they cannot choose the music because there are several embryos inside each incubator.
Perfect. Thank you so much. Actually, it's not a question, but someone agrees with us as well. That is cool about the music.
Again, it's nice to explain it, but I think it's better if you connect to our webpage and look at the images of these concerts and these developing embryos and the Barry White music is just fantastic.
Perfect. Thank you so much for answering that question. Definitely interesting. And now let's go to the next question we have. So is the embryo observation link an extra charge on top of time lapse?
No, it's included. As I said, almost all our patients will use time lapse technology, and the link is one of the reasons they choose it. I think it's a pack. It makes sense to give the opportunity to get the best embryos and to see it. So yeah, it's included.
Perfect. Thank you so much for confirming that. It's another question. It's about the cost. So not sure if you can answer that. So the cost for own eggs and sperm IVF.
Well, I think about pricing, it's easier to send us an email, and we will get a specific answer.
Sure. As I mentioned, you will find the link right there. Once you click on that, there will be contact button, and the team will be happy to explain all the details. So should be okay. We do have some questions left, but we will be slowly finishing. So if you have any questions you would like to ask, don't miss your chance and go ahead, type this right now. And now we have another questions here. You mentioned adenomyosis earlier. What treatment do you do for this condition, and when do you do it?
Okay, well, adenomyosis, we know, is quite an important condition for repeated implantational failure. It depends on the degree and the average of the uterine cavity which is affected by adenomyosis. There are some patients that have just little focal adenomyosis that doesn't have any effect on implantation. There are some of the patients that you know that because they have quite important pain during the period and that they have severe adenomyosis. In these patients, we need to stop this activity under the endometrium to reduce inflammation and to increase the chances for implantation. So using some treatments like agonists before transfer is one of the options that we will use before transfer. In some patients with focal adenomyosis, probably 1 month of treatment will be enough, just one injection. In some of the patients that had already had implantational failure and they have severe adenomyosis, sometimes a 3-month agonist treatment to stop all the hormonal axis from hypothalamus, hypophysis, ovary, uterus is mandatory before transfer to increase the chances of an implantation. So from one to up to 3 months of treatment.
Thank you so much for your advice in such case. And here's another question. Can I ask if there is anything in particular my husband needs to do to ensure maximum quality sperm before the procedure in relation to lifestyle diet? He's currently taking well-month conception, vitamin D, and omega-3. Is he okay to still take alcohol? And if not, at what stage beforehand should he cut it out?
Mm-hmm. Of course, not only for fertility, but for any health purpose, we should recommend to reduce any toxic, any drug. Of course, smoking should be avoided, and alcohol, even if, of course, there are not specific trials, if 1 glass of wine is enough, or 2 or 3, of course, we should recommend to reduce any toxics during treatments. And of course, having a healthy diet, exercise, etc. I think that has shown to reduce, especially the problem of DNA fragmentation in male condition. I see that he's been taking antioxidant treatments. This is good to reduce fragmentation, but be careful not to do it more than 4, 5, 6 months, because we could have a rebound effect. So if the andrologist just told you to tell this omega-3 or this antioxidative treatment, just you should do it for 8 or 12 weeks before treatment, but no more than that, and seeing that we can get the opposite effect that we're looking for. Okay.
And thank you so much again for explaining this to us. And I believe now it will be last question for tonight. However, if you have any questions left, go ahead and type them all in. Okay. And now let me go to the question. So does the embryoscope mean the embryos can be observed without having to open the incubators to check on their development? Does opening the incubators affect their development? Have been told about different options.
Mm-hmm. Yes, time-lapse technology gives us the opportunity to keep the embryos inside the incubators for all the embryo culture days, which means between 5-6 days. Of course, there's a camera inside that will take a picture every 5-10 minutes without the need of getting the embryos out to the microscope, taking the picture and back again in. So the main problem in conventional incubators, of course, if there was one incubator per patient, we would open the incubator once a day. But of course, in standard incubators, probably you will have 10, 12, 15 patients keeping their embryos inside. So probably you will need to open the incubator up to 10, 20 times a day to see an embryo. And of course, before transfer, if you need to reobserve an embryo, you can double these numbers. And of course, this doesn't happen in time-lapse technology, where you can get the embryo out just for transfer, and you don't need to take it out during embryo development. I think that, yeah, there are different options in time-lapse technology, and as I said before, I think that we do not have enough evidence. I think that every lab has its routine and they know their results based on the incubator they are used to use for embryo culture. Here at Institute Marquès, we really, we're happy with, at this moment, with Embryoscope. And as I said before, just because we can also add the embryo mobile technology.
Perfect. Thank you so much for your answer here as well and your advice. I believe, as I mentioned, I don't see any more questions, so that means we will be finishing. And just would like to thank you, Dr. Àlex, for joining our initiative, Stronger Together initiative, for your expertise, for all the details you have provided. That was definitely useful and very interesting indeed. So thank you so much. There are some patients that definitely are thankful as well. And
thank you all. Thank you very much for giving us the opportunity to share all this information. And I think that sometimes surprising patients and telling them that there's some things I've never heard of, I think it's also interesting. And of course, always tell the patients to ask, of course, any doubt that they might have through our webpage or through the links that you're offering them is very important. And I think that they just should be taking the opportunity, taking the advantage of sending any questions and solving any doubt they might have before starting any treatment.
Of course. And since we now can just need to wait, I believe that you have learned a lot from today's online patient meeting. So thank you all for joining us as well. And you already know at 8 p.m. UK time, we start a new event. So hope you will be able to join us as well. And Dr. Àlex, there's another one. Hopefully we can visit your clinic sometime. So thank you for those comments.
Even if you don't come, just virtually, you can meet us too.
Right, exactly. Perfect. And just one more thing, remember that this event has been recorded. You will be able to find it on our website very soon. We are definitely working hard on it. You can find it on myivfanswers.com. You can follow us on our YouTube channel or Facebook page, Instagram, and that way you will know when the video is ready and uploaded. You will receive the notification, so feel free to subscribe right now. And thank you so much again for joining, Dr. Àlex. It was a real pleasure. I really do hope we can do it one more time soon. And have a lovely evening. And stay safe as always, right?
Thank you very much, Caroline.
Thank you.
Bye-bye.
Bye.